Okay, are we on, Minu?
Yes.
Yep.
Okay, hello everybody. My name is Daniel Cherqui. I'm a liver transplant surgeon and hepatobiliary surgeon at Paul Broos Hospital in Paul Broos. And Gonzalo Sapisochin from Toronto University is chairing this session with me. This is an initiative from the American Journal of Transplantation on the use of minimally invasive surgery in liver transplantation, mostly living donor liver transplantation. The first webinar was about donor hepatectomy, and the second webinar today is about the use of minimally invasive surgery, both laparoscopic, but mostly robotic surgery for transplantation itself from living donors, partial grafts, or for full grafts from cadaveric donor from the United States. And we have here KSO from Seoul, Korea, Safi Dokmak from Paris, Pital Beaujon, Adil Khan from Washington University, St. Louis, Missouri, USA, and Max Malago, who is representing Dieter Broing, I suppose, or yourself for the Riyadh group. So so today we're going to talk about the use of minimally invasive surgery for graft explantation and implantation, which is a very, very different topic from the donor hepatectomy. And maybe Gonzalo, you want to start with questions?
Yeah, I think thanks, Daniel. We just got joined Mohamed Rela, also from Chennai. Hi, Mohamed. So it's great to have amazing experts here in the topic. So I guess, this is definitely a very, hot topic, exciting. I think with the advantages of I guess mainly the robot. I think this, many groups have started to think about this. I guess I'm going to start with a controversial question, and I would like all the panelists to give us, their opinion. Like, why do this? Like, why do a liver transplant with minimally invasive surgery? So I don't know who wants to start with that.
Then I think the appropriate thing to start would be for Daniel. He wrote an article after the first publication. Is this a progress or a progress? I would like you to repeat what you have said in that article, whether you feel this is a progress in the first instance.
Okay, so I pre-recorded the video. I mean, a presentation that I sent you the link yesterday. I'm not sure you saw it, which was also progress and progress. So basically 2 years ago, I received from the AJT the paper by KSO on it was laparoscopic living donor liver transplantation with the subtitle "Dreams Come True," and I was a reviewer for this paper, which I really enjoyed and I really was impressed. But I had mixed feelings about it. And so I was invited to write an article which I called Prowess or Progress. And my conclusion was this is definitely a prowess, for sure, because this is the last frontier of minimally invasive surgery, the liver transplantation. Nobody would have thought that this would be possible. And so I think it's a dream come true for surgeons, virtuosos. On the other hand, I'm not totally convinced that it's a progress, because I can't really see the advantages. This is a life-saving procedure in very sick patients, and I believe it's so much different from donor hepatectomy. Donor hepatectomy is a healthy person, and it makes a lot of sense, like in kidney and living donor nephrectomy, to make it laparoscopically. Or minimally invasively. However, for the liver transplant people who are very sick people, I believe, number one, it's only a very few selected patients can do it, can be candidates. Number two, only a very selected group of surgeons can do it. And number three, and more importantly, I don't see the point. So so for me, it's a prowess. And I think only the future will tell us if it develops into a meaningful operation or just I don't know.
So again, Mohamed wanted this add-on from Daniel. That was but let me go back to my question then, Mohamed. maybe you can start. Like, what is the need and why do this?
Okay. Can I can I start as a pro person? I can have an argument against as well. The pro argument for this is, first thing is a technical demonstration of feasibility. Okay. And I think it's important that it's a safely done procedure and the feasibility is shown. Whether we take it on and follow it at a later date and it's going to be useful for the future is a second question to make anyway. I mean, when Professor Starzl did the first liver transplant, this question would have come into many people's mind, particularly when a series of patients died as well, and people would have thought, this is completely out of order, and so I first think it's a progress in one way, at least for now, that the feasibility is tested, and it's possible, as Daniel says, at least some people will be able to do it successfully, and if it can be consistently done safely, I would say that's the first progress that we make. I think the second progress is going to be whether it's applicable for individual patients, how many will benefit, how we are going to modify the technique to benefit or add more patients into it. I think that is a discussion that we can take on today as we progress. I think the first thing, the progress that has been made is that the feasibility has been demonstrated by at least by one or two surgeons around the world. And we need to seriously look at it to see how safe it's going to be as it actually progresses to other surgeons around the world.
Adil?
No, I agree with a lot of the comments made. I think that the first thing is to document safety before we can move on to efficacy. And I think that, we are getting there where we have shown that it can be done safely. A year ago, I would have maybe mirrored Dr. Cherqi's views that maybe this is more of a prowess rather than a true progress. But I think that the more we do, the more we realize that how good the robotic platform is, especially for fine sewing. And, we do a lot of kidney transplants on the robot. And with experience with that, we realize that the view that you get of the vascular anastomosis is better than you do open. And I feel the same way for implantation of the liver transplant. Now, the hepatectomy, like we mentioned, there are two parts of the case, the hepatectomy and then the implantation. I think that the hepatectomy is a good place to start off with. And I think even if you can do that robotically and then do the implantation through a midline incision, that still saves a lot of morbidity and it definitely indicates progress. But those are my views.
Dr. Docmac, you've been doing this actually laparoscopically. I mean, your paper in AJT showed some, series of cases. I think a very good population to start to do this with these neuroendocrine tumors, no cirrhosis, etc. Why don't you briefly explain, again, the point of why doing this in this population, and maybe explain very briefly your technique, which is a little bit different than what Dr. Rella and Dr. Khan just talked about.
Yes, of course. For us, patient safety is very important. And as you know, as surgeon, we have now we have many experience in liver transplantation, in minimally invasive liver and pancreatic surgery. So I think in very selected patient with cirrhosis or even with neuroendocrine tumor, I think hepatectomy really is feasible. Laparoscopic or robotic is feasible, but I think for the implantation phase is much more complicated. So for us, for the moment, we still do the explantation by laparoscopic approach and the implantation by the small midline incision in order to have some idea. And of course, later we will see if it is possible to do all laparoscopic or robotic. But of course, when we do it in very selected patient, like patient with neuroendocrine tumor, which is with not very severe cirrhosis, probably for the moment, only the advantage is the parietal advantage, because with a small midline incision up to 15 centimeter, I think we can do safely the anastomosis. We don't take any major risk on the technical feasibility of anastomosis or the patient. But of course, we will see with the time if we can improve. Probably, I think the most difficult one it would be the caval anastomosis. The caval anastomosis. And probably one day the advantage, it could be not in very selected patient, in obese patient who need major incision. I don't know if it could be feasible in this patient or not. For the moment, it is only very selected patient, explantation by minimally invasive approach and implantation by small midline incision. I think we should need more patient in order to have an idea about the safety and about the advantage of this approach.
So before we go ahead, go ahead, Daniel.
No raise his hand, but I think that KSO should come in.
Yeah, why don't we get Dr. Seuss and Dr. Malago's comments, and then we'll go back to you, Mohammed.
Yeah.
Okay. Actually, minimally invasive surgery is the goal, a final goal of any abdominal surgery. And then, anyway, with the minimally invasive surgery, even in the liver transplantation, I think we can reduce actually some complication. Like it's a big operation, and then we can reduce the scar, reduce the wound, and then it may be very comfortable to manage the patient after operation. Like we can reduce the pulmonary complication, and even I think is they become a normal person after liver transplantation, but they will have a big scar after liver transplantation. And then one more thing is we are doing more liver transplantation in better patient, I mean less sick patient, and then they will have the liver transplantation. We are doing more comfortable situation, and then we can do minimal invasive in that case, and then we can reduce the scar, and then they will make a more like a donor hepatectomy. They will have a good life after big operation, but with a very small scar, and it is very comfortable to them. And I think so. It's a final goal to our all abdominal surgeon is minimal invasive surgery, even in liver transplantation, I think.
Your last comment about this question, Max.
Thank you very much. So I understand the comments of Daniel, very well posed. You say, guys, you are mad, what are you doing, is this needed? However, my next comment is, until you don't see, you don't know. And it is remarkable to see what you can do with minimal invasive surgery and with the robot. I go back on the comment of Adil. If you do hepatic, pancreatic surgery, and you do donors, and you do kidney implants, you realize how the technique can be used. I believe we don't do this for surgery, for industry. We do it for patients. And I think that there is a niche of patients, a group of patients. You are right. Very many patients are sick, extremely sick. If I have the chance, I'll show you a couple of slides on what we have done in our 7, and the 8th is ongoing. And of course, you need to select the patients, but definitely I can say it's not for surgery, it's not for the surgeons. The patients benefit. A patient benefit because it is good. You need to be smart in the beginning. I don't know what will be the limits. We select patients. We don't get patients with major pre-operations, with impossible portal hypertension, good Chiari. There are limits to this, but it is feasible. And beyond feasibility, I'm afraid that more and more people, when they become comfortable, they will become convinced. And again, until you don't see, you don't believe. And you believe me, because I was skeptical myself, but I think it is not so bad.
Mohammed, you had your hand up. You had a question, comment?
Just an answer to Dr. Dokmak's technique. I'm not saying it's a way forward. I think in the very early days, we also talked about mobilization laparoscopically or robotically and implanting with the midline. But I have to say, we have at least done over 120 transplants through a midline without any laparoscopic assisted mobilization. Particularly the kind of cases you're talking about, which are non-cirrhotic, neuroendocrine tumors, it's very easy to mobilize the liver through the midline open as well. So I don't see the point in actually starting off with laparoscopic and then implanting with a midline. So that
how big is the midline incision? How big is it?
It's between 12 and 14 centimeters.
So below umbilicus or no, above umbilicus?
Not below. It's supraumbilical.
Okay.
We've got at least 120 transplants done with a supraumbilical incision. If it is difficult,
in adult patient with a cirrhotic liver, right?
Adult patients. So I mean, we have not actually published it. We have done it. One of the problems with this technique is that we can't train our juniors when we do that. So that's been one of our problems, that the fellows are all standing there and the seniors are doing the hepatectomy. So we have decided that, they become unhappy, and that's the only reason. I think in a significant proportion, you can do the transplant through a midline incision. And if you have to extend it down for difficulty, so be it. It still is a midline incision.
Yeah.
The next step.
And I think it's a good. I mean, I was going to mention. I mean, we do here in Toronto many cases, even cirrhotics. One of our surgeons does all the transplants through a midline. With a good Thompson retractor, you can do it. And certainly, all our colorectal patients that are similar to the neuroendocrine non-cirrhotics all have been done through a midline, except one very obese patient. So it's doable. So I guess, I think Dr. Dokmar has his hand up to reply to this discussion, and I think Max wants to make a comment too. Yep.
So I agree.
I think. Okay, go ahead, Max.
Using the midline is no secret. Since 20 years we use the midline for every hepatectomy, even for transplant. But I believe that the advantage here is to do it truly like a minimal invasive operation. In fact, with the transplant that we do, right liver, some reaching 700 grams, are done not through the midline. Through the midline, to me, is a hybrid that is no use. You can do it open. We do it with the trocars at the level of the umbilicus and insertion and extraction of the graft through a Pfannenstiel incision.
Okay. Yes, of course. I don't.
Sorry if I say this is the real advantage of. I echo the comments of Professor Su, who said about the incision. This is the real advantage, to do it through the Pfannenstiel.
Yes, of course, I know that we can do liver transplantation fully by midline, but for us, it was a very good thing to start hybrid. This means that to do the explantation by laparoscopic and implantation by midline, it was a very good thing for us to start minimally invasive surgery in recipient. But of course, we can do it by midline. And as we mentioned in our papers, I think this approach will much more develop in living donor liver transplantation, because by definition, you have a small liver of very good quality. We do only cadaveric liver, so we don't have this small liver. This is the problem between cadaveric and the brain death donors. But of course, we can do full liver transplantation by, I think, small midline, very selected patient, yes. But if we have a little big patient, I think we should at least do under the umbilicus in order to have liver transplantation.
I'll make just a small comment that laparoscopy with a pneumoperitoneum is much more, or robotic, is much more comfortable than struggling through a small midline.
That's correct. I mean, if you think about think about donor surgery, when you do first minimally invasive surgery in donor side, we do some small incision and hybrid approach. But I think it is more difficult than pure laparoscopic technique. now. So it's sometimes it's more dangerous to do that, and the more if you do totally hepatectomy by laparoscopy and the middle line incision and the very small 12 to 14 centimeter, and then the upper midline incision, it is the personally very demanding procedure. But if you close that and then put the pure laparoscopy, if you do laparoscopy, is sometimes more comfortable than a small incision. It was true in the donor surgery. Now we complete 100% is now in donor surgery, now in pure laparoscopy technique. We don't use any minimally incisional surgery in donor surgery because it is more difficult and more dangerous than pure laparoscopy technique. We know that. It's true. I think it will be true in recipient surgery too. And then now we are struggling, but we can do more do recipient surgery more comfortably in future. Maybe we can do more some technical advances in that. So it's a minimally incisional surgery is not always. I think it is not a good approach. Pure laparoscopic technique is much better approach, I think.
You?
Yep. So I mean, I heard the comments about the doing the whole transplant through a midline incision. I think the US is a little bit different than that. We have very large patients, and it's almost impossible in most of our patients to do a liver transplant through a midline. The other comment was about a phanestoel versus a midline extraction port and internal port. When we started doing it, one of the main concern was to do it in a safe way, which means that for every misstep that we can encounter, we should have a way to get out. And I felt that putting a peri-umbilical assistant port for extraction and putting the liver in would also allow the backup of putting a hand in case you got into bleeding from the cava or something where you could control it. And with the phanestoel, sometimes it's a little bit of a struggle to get your hand all the way up to the upper cava in case of a problem. But I think as we get better, and then I think that's probably the natural evolution of it.
But it looks like I have a comment about that. We usually we think is in obese patient. It's a laparoscopic approach is we think somebody think it is more difficult, but I think especially obese patient, laparoscopic approach is better than open procedure. We can see the more good view than even in the obese patient. So in the obese patient, I think is some advantage in laparoscopic procedure. So, and also is a hand, maybe it looks like a convenient, but when you do the heart procedure, it is very inconvenient. And then I think a pure laparoscopic approach is better than any hand procedure.
Gonzalo.
So just to follow up on Adil's comment, and just to play a bit devil's advocate here, like also, I mean, one of the things we're not talking about is as recipients get more obese, donors get more obese, and the liver that you're going to be implanting is also bigger, right? And here we talk about whole grafts. So, I guess that incision will also get bigger and bigger to be able to introduce the graft. So why don't you comment a bit on, on your technique on how to I mean, you're not going to be, I mean, I've never, I guess most of us or some of us here have not done this. Like, how do you squish that graft is? How concerned are you of squishing a big, let's say 2-kilo liver for this, BMI of 40 patient through a small, incision around the umbilicus?
Sorry.
Go ahead.
I can tell you because we use only cadaveric livers, so we don't have living donors. And with cadaveric liver, even with 15 centimeters, we can introduce a large graft of 1,500 grams. I think with 15 centimeters, we can introduce easily 1 kilo 500 grams of fuel graft, 15 centimeters.
Okay. Other comments?
I would agree
Of course, we do live donor mostly, and that is a disadvantage and an advantage. The disadvantage is that you have less volume, but the advantage is that you truly can introduce these organs through the funnel still. And again, technically speaking, if you have, I agree that safety is first. And in fact, we are thinking with experience maybe, and with some modification of clamps, because we need to speak about the technical futures here when you do fully minimal invasive surgery, attacking the cava. So the advantage of having also the funnel steel, yes, you need the long arms or long surgeons, agreed, but you are completely out of the action in the middle of the abdomen. You have a gel port. It is truly going to be in your way. This way, the console surgeon needs a long hand, and also to be careful not to get some hit from the robot moving. But that's all. It is very, very, very advantageous to be out of the field and ready to help up to the cava if needed. So safety, I believe, is not an issue.
May I?
Go, Daniel. Yeah.
I would like to continue on the issues that I raised at the beginning about price. What my mixed feelings when I saw the paper that was submitted. Number one, I want to let you know that I'm a very laparoscopic or minimally invasive friendly surgeon. I love minimally invasive.
We know very well.
That's one
you are
point.
one of the first.
And number two, when I saw the paper by KSO, I saw that a limitation was the time of IVC clamping and portal vein clamping. The IVC and portal veins, because you gave a timeline, was 3 hours. My patients don't really tolerate 3-hour clamping times. And so I think that it should be improved, and there are a couple of ways to improve that. One is the use of venous bypass that Adil has used for cava. But if you add a portocaval shunt, a temporary portocaval shunt, then you drain both portal vein and IVC through a cavo-caval bypass. And then you get into a much more comfortable situation because you don't have to run against the clock. This is my comment. So I think
if you do portocaval shunt, it is very hard to manage the IVC cramping. Anyway, we have to cramp the whole cramping during operation. If you do portocaval shunt, you can just temporarily reduce the portal pressure. But anyway, we have to the cramp all the IVC during anastomosis.
Relying on spontaneous portal hypertension and shunts is very unreliable and very unpredictable. And what you have,
so that is a big problem. But I think recently, the anesthesiologists manage very well with the IVC cramp, IVC total occlusion. They are doing very well. They're doing very good job. They are maintaining very good pressure during surgery. So anyway, we need a very good patient selection. We need some good recipient with the preserved cardiovascular function. Otherwise, if there is some problem in heart or something, cardiocirculatory problem, they will not withstand that. So this is one thing. Right now, we cannot do that.
One thing is that we have transplanted cadaveric livers for 30 years, and it used to use bypass. We very rarely do it, but the bypass. I'm just telling you, you will like it if you use it. But that's just
we don't have experience in bypass for maybe 10 years.
This is why
we haven't used any bypass.
Adil wants to comment.
That's the problem.
Yeah, no, I mean,
go ahead.
That's a great point. In none of the papers of bypass is mentioned, but I think that again, when we're starting to doing these, we want to do it safely. And we talked about it, and we felt that doing it with veno-venous bypass adds an element of safety. One, it makes the hemodynamics a lot better, and you're not worried about clamping the cava, because the last thing you want, especially in the early experience when you're already stressed, is clamp the cava, have the patient be hypotensive, and then you're sewing and trying to go fast. So that takes care of that. It also allows you to create a portocaval shunt if you need to. A lot of the times you don't. But I think that the other very important part is if you have that available, you can essentially ensure that you will get the hepatectomy done robotically. First thing we do is free up the cava above and below so that in case we do get into problems, you can clamp the cava, you go on veno-venous bypass, clamp the portal vein, and you have everything excluded and the patient is stable. And that allows you to control any bleeding on the cava, easy access to the hepatic veins, and it just introduces a big element of safety, which gives you a lot of confidence while doing the operation, in my opinion.
It's rediscovering liver transplantation like in the 1980s with Chris Broch, Max.
Yes, but I have to say, again, I speak about the experience here, which is live donor, so it's partial grafts. And the hepatectomy, I think, is no problem. Once you have done the hepatectomy, doing the implant, I understand the concerns of doing a total liver with the complete clamping or so, but let's be honest, we do piggyback also in normal liver. We put a Satinsky and we partially clamp the cava. In our cases, we never had to do total caval clamp. We do a partial clamping of the side bite of the cava for a right liver implant, like you do with a live donor. And the time of implant, let's be honest, you insert, the hand is there, it's hand assisted. We are not saying, we probably will come with modified clamps and so to do also a total laparoscopic complete, but the hand for now, safety. You insert a side-by clamp, you partially clamp the cava, you do a very comfortable anastomosis with the robot of the cava, 2 runs, 1 and 2. You do the portal vein and you open and it is an hour, even less. So for us, this veno-venous bypass, all these things is not an issue. Sorry.
Okay.
Yeah, yes, but how to manage the port side of the robot, the hand-assisted approach, and the clamp for the caval? You have many things on the abdomen of the patient. You do it in the flange steel, the port side?
Yes. You insert the clamp in, you clamp the cava, you just pull the stitches that you put on the right hepatic vein, stapled, of course. Side clamp, open, saw, then it is a right lever, so you don't have a lot of things in front. The only problem is to approximate the portal vein to the portal vein of in donors. Robotically, the portal vein is non-existing, it's very short, and that's it. I have to say, honest, it's not easy, but it's easier than you think once you start. This is
Mohammed, Mo wants to talk.
I mean, my problem, I know, Max, I've seen a video also of data with a side clamp without having to clamp. Suksu just commented that the cava has to be clamped. But at the moment, at the time when we are trying to develop a technique, I've tried almost 9 recipients now, and we are moved in stages. And now I can complete a hepatectomy in 2 hours. So, like an open operation in a cirrhotic liver, hepatectomy has become comfortable now. The implantation also we can do, but one of the problems with implantation is being able to complete or to get an absolute hemostasis, because when the intraoperative pressure is high, what looks like absolute hemostasis, when you're closing, the drains become bloody, and not having, if you had done a phantom steel incision to insert and extract the cirrhotic liver and insert the new, the graft, and I've always worried that if I have to make a midline for these patients to complete the transplant, it becomes 2 incisions, which absolutely defeats the purpose of really having a single lower midline of phantom steel incision. So I personally made a decision that until you're comfortable that you're never going to need an upper abdominal incision to secure hemostasis to complete the operation, I would never do it through a fan and steel, inserting the graft through a fan and
You
steel.
will be convinced.
And that's been my approach.
You will be convinced.
I know that the data has done it, and but for me, if you do 10 cases, even in 2 or 3 cases, if you have to do 2 incisions to complete the operation, that would be unacceptable. So I've taken a policy that until I've 10 with no problem.
The midline is easy to extend. Midline is easy to extend.
Yes, that's correct.
So my question is, Dr. Rana, so you do like our technique, you do the same.
Yeah, but the difference is the size of the incision is only to be able to insert the graft. Once we insert the graft, we actually close the midline incision. It takes 3 minutes to close because we don't have a gel port. I found it very inconvenient to have a gel port there. So we actually close the incision. It takes about 3 minutes to close the incision and then do everything robotically and then actually open it to take the clamps out. I mean, I have to say it's a development phase for us. I mean, I'm not still confident enough to say that I'm happy to make fan and steel and insert the graft. I mean, I can show you a video. It's half of the upper midline incision just to be able to use the right. Maybe a whole liver can't be inserted, but a right lobe can be inserted very easily through a transverse manner into the abdomen with a hand in place. You can position it properly, packs in, and then close the midline and then start the anastomosis robotically.
Thanks.
But I feel uncomfortable that I was able to.
Yeah, that's true. But in the beginning, maybe it's okay. But midline incision doesn't look like to me, it's not like the minimal invasive surgery, true minimal invasive surgery.
Right.
It's
You're purist.
incision is kind of open surgery. So,
maybe
finally we have to go to the fan and steel incision. The different incision line is a true meaning of a pure laparoscopy technique. But anyway, we can make a midline incision. I think sometimes we small incision and put the liver in the position, and then we close the only peritoneum, and then make the pneumoperitoneum again, and then we can make an anastomosis like that. We can make a pneumoperitoneum, maintain pneumoperitoneum, and then the suture anastomosis again. But still is doesn't look like to me is a pure laparoscopic technique.
So I think maybe, we obviously have the fortune here to have people with some experience. I know both Dr. Malago and Dr. Khan has some, short videos. Maybe why don't, Max, you go ahead and share.
I don't have videos. I have the numbers of what we have done. I have the results.
Show the numbers very quickly,
which may be more illustrating of.
Can you share your screen and show us?
How do you share the screen here?
You have on the line in the below the green share screen. There's a green spot. Can you see the?
And then we'll get Adil also. I think you have a short video, Adil.
Maybe Adil can share. Maybe Adil can
disable host, disable participant screen share.
Host. You must agree. AJT.
Okay, so Minu, can you make everyone host?
Yes.
Thank you, Minu.
Yeah.
Thank you.
So now, okay. So
thank you, Max.
Of course, this is how you do this. This is Dieter, should be here, but unfortunately he's not. And actually he says hello to everybody and apologies for him not being here. So here we have our numbers and our, just a second, yes. We have done 7, 8 is ongoing. I think it's very important to say the donors here are done all completely robotically since more than 2 years. And we have 100% penetration with more than 300 in the last 2 years. So now let's look at these donors. The donors are all young, but we have all young donors in this country. We have a predominance of males, 4 to 3. This is, of course, small numbers. This is post-operative results, which is nothing special in a donor with an INR reaching 2.7 in 1, but otherwise normal. The bilirubin reaching 50 and going down. AST, ALT, we see very low on day 3 and day 1. All our donors were right, and we will come to this in the discussion. We think you can also do left, but left poses a bit more challenges with the positioning of the donor, while the right liver stays in the right hepatic fossa, and the cava anastomosis is more comfortable. You can see the operation, the duration. It is, yes, Danielle agreed, it is longer than a transplant, but it's not overly long. And the donors had no complication. Hospital stay is 4. Now, the recipients, I think it is very important to speak about the recipients because, as you say, safety number 1, you need to select the recipients. I would like to spend later with you guys, maybe some words on the selection of the recipient, maybe Dr. Su. You can see the age, you reach even 76. They have BMIs from 47 to 27, however, even small, relatively small patients.
Max, speak.
Yeah.
I'm sorry, you cannot make a full presentation here. I'm sorry.
Okay.
This was not the plan. So please try to just.
Okay, then the recipient adult characteristics, they are not very much different from our normal. Only the MELD is much lower. You can see 21, 16, 23. MELD is low. It shows patients. Complications in recipients, this is important. Hello?
Yeah, we can hear you.
I heard a shout, never mind. So one patient that is rejection, one patient and a bile.
No details, please, no details.
Okay. No, but what I'm saying
so
is
we understand that it's a regular, the results are the same,
and
right?
Hospital stay is 13 days for all. That's it. Thank you.
Thank you. Sorry for rushing you, but we.
So I guess before we go to Adil's short clip or short video to explain a bit the technique, Max. I mean, these were I guess 7 cases, but like how do and maybe everyone can comment briefly. How do you decide today who you're offering, a fully robotic?
I think the most important thing of the discussion today.
So how are you guys doing it? I guess how are you? Sorry.
No, I thought. Okay, sorry for interrupting. I thought that at the end we would maybe ask that.
Sure. So we can do that too. That's fine.
What's the percentage of patients that are eligible, and how do we select them? And so maybe we continue with technique. I'm sorry.
No, all good. So Adil, why don't you share your screen? We can see a video and then we can talk about that at the end. We have 15 minutes. I just want to make sure we have time.
Quick video. It's about 2.5 minutes. Can you see my screen?
Yes.
Yeah.
I'll just start that off. So, recipient hepatectomy, use the vessel sealer. Go to the cava first. This is the porta hepatis dissection. Dividing the artery. Portal veins in the back. There's a bile duct. And then I really like this approach. I think Dr. Su described it, or the left to right approach of liver mobilization, and it allows minimal manipulation. This is the final view before the explant. So there's the full cava dissected free. This is the right hepatic vein and the portal vein. And then you can see the artery that's been divided. And putting a bulldog on the portal, dividing it, and then firing a stapler across the right hepatic vein, and that completes the hepatectomy.
So at this stage, the portal vein is clamped, and so is the IVC, it looks.
So portal veins clamped. It's got and the IVC is clamped, and I'm on veno-venous bypass.
Okay.
So there's no stress. And this is a side-to-side cavostomy. We use Gore-Tex just because we like the way it handles and it doesn't really fracture easily. But this is a nice big anastomosis, good visualization, a lot better than we get open. So I really like the sewing part for the robotic implants. Then the portal vein. This particular portal vein was fairly small, but essentially the same technique as open.
You mentioned in your comments that the recipient had a spontaneous splenorenal shunt, right?
Yes. So we like to kind of, find somebody with some cirrhosis, if there's no cirrhosis, the bowel gets very congested with portal vein clamping. So if there's a little cirrhosis and portal hypertension and some shunts, then they tolerate portal vein clamping a lot better. That was reperfusion, so clamps are off. So it's, the pneumoperitoneum helps with reperfusion too. And there's the big cable anastomosis and the portal vein anastomosis. And then, the advantage of a deceased donor is that the vessels are bigger, you can make patches, and I think it's just a little bit easier. And again, great visualization. This donor had a replaced left, so we're using the splenic patch, completion of the artery, then opening of the artery. And then finally the bile duct. So there was good size match. This was an interrupted 5-OPDS anastomosis.
Yeah, beautiful.
And then the final view, so you can see the portal vein there, bile duct there, hepatic arteries, the replaced left, and thing looking good, and then the portal vein in the back. So that was it. I'll stop sharing.
Very nice. Any comments?
It's really nice to see that you, very important in robotic or to mark the sides of the vessels, both on the donor and in the recipient, not to get twists.
Yeah, I mean, I love standardization and safety. I think those are the two most important things for success.
Yes, I think for, sorry. So I think for this approach, the major problem is the caval anastomosis. For the portal and the other anastomosis are, even if we do with a small midline incision, the portal, the biliary, and the artery are much more superficial, and we can do it with, the problem is mainly with the caval anastomosis.
I would say that what we see here is that this is feasible and it will improve. Whether you use some kind of caval or portal decompression we'll see in the future. But I don't know what kind of patient you transplant. We transplant 70% of our patients have a MELD score above 25 or 30, and the rest have HCC. So this is the kind of patient that we have. So I was wondering whether you have an idea of how many patients would be candidates for a minimally invasive recipient surgery.
I think it is now our indication wise less than 10%. Less than, if you strictly apply our indication, maybe we have to consider the donor side, the donor graft, and the recipient side together. So it's very hard to select a proper recipient. But we will expand the indication and more. I think we can do more and more. But now is safety concern wise, I think is around the 10 to 20%, less than 20%, 10%.
Okay. Please, the others.
Yes,
I think selection is most important. And as we say, selection in the beginning is the secret, because if you make one mistake, one death out of 10 is 10%. It is not acceptable. So we are very, very cautious, and the selection is on the patients, not too high MELD, so prevalently tumors, not too much portal hypertension, and the liver, not too much hepatomegaly, because the hepatectomy then becomes difficult. And previous operations, of course, not to waste time with adhesiolysis, even though we did one previous, and it was a bit of a trouble coming from the funnel steel. I think that is the main thing. Percentage, I think the percentage will increase. For now, we are in an exploratory phase, and I think having an estimate of the percentage of patients you will do is very difficult, because
what's your expectations?
My expectation would be 20% of patients, and maybe even growing more with experience. I also see that we will do more and more tumors and less cirrhotics, and so there will be many.
Believe me, we have cirrhotics, but we also have tumors.
I think we, of course, if we work in a liver transplant unit and for the explantation, I think, or we can do it safely by laparoscopic or robotic. I think about 20 to 25% of patients we can do safely without a major risk on the recipient, 20 to 25%. This is mean not very large segment, not severe portal hypertension, no peritonitis, 20 to 25%.
Adil?
Yeah, I think, I mean, sure, that's an ideal number, but I think that it's there are a lot of logistical things that are required to do this. I mean, you know, if you're doing living donors, you need 2 robotic teams. You need 2 robotic surgeons, one for the donor, one for the recipient. You know, for a lot of us, we don't have the luxury of having 2 robots available at the same time. So so that definitely does factor into what the final number is going to be. You know, we prefer patients with HCC, you know, because we do deceased donor, so they get exception points, and their listing MELD is a lot higher than their actual MELD. We prefer a lower MELD. But some portal hypertension and cirrhosis is definitely preferred than no portal hypertension, because, you know, without portal hypertension, they don't tolerate portal vein clamping for too long, and then the bowels get distended and congested, and it just obscures the view. And one more thing that is really advantageous for us doing deceased donors is the availability of commercial normothermic devices. You know, that sort of takes the stress out of the hepatectomy. You don't have a cold ischemia time sitting in the back of your mind as you're trying to get the liver out, because the liver is sitting on the pump. And we find that very advantageous. It also allows us to plan the operation, so we can start very early in the morning, rather than, you know, doing it in the middle of the day and then continuing through the night. So I think all of that, in my mind, are little things that will allow for wider adoption.
Yeah. I think that it's definitely fascinating, Adil, and I think it's very interesting. You know, as you were explaining this, I was thinking, so now we're going to do liver transplants where we're adding the cost of the robot plus the cost of, you know, of the perfusion of transmedics or whatever perfusion machine, plus and plus, right? So, I mean, I think it's fascinating. I think at some point there has to be some cost effectiveness discussion too about the advantages in the patient and all the cost of adding all this, you know, extra technologies. Dr. Su, any comments from your stand on selection?
I'd like to comment about laparoscopic versus robotic surgery. We are very comfortable in laparoscopic surgery, more comfortable than robotic surgery. In donor surgery, especially in donor surgery, we don't have much experience in robotic surgery in donor. But laparoscopic surgery is now a very standard procedure, and it's faster, like 4 hours, less than 4 hours, so we can do donor surgery. And then even in the recipient surgery, definitely when you do the hepatectomy, laparoscopic surgery is a more advantage. I think is better than robotic surgery. But even I can do the anastomosis with the laparoscopic technique, but robotic anastomotic surgery is if we can do artery and biology is better. But still, we can do laparoscopic surgery even in recipient with less cost, especially in Korea. It's very expensive to use a robotic system in Korea.
Mohammed, do you have any expectations or vision about the future of this procedure?
Yeah, at the moment, we have a very cautious approach. I mean, I believe that non-cirrhotics are not an option. It's been mentioned before. You have to have some portal hypertension, but you can't have too much portal hypertension, or can't have too high MELD patient where we're very oozy to begin with. And the second problem, as Adil said, is I do not want to offer a recipient robotic implantation when I don't offer a donor. So the priority is actually to offer the donor. So unless I have a bigger team where we can do both of them, as a donor and recipient. So that's going to restrict, again, for most people at the beginning, to be able to, in living donor, to do with the recipient without doing the donor wouldn't be acceptable. But in Saudi Arabia, DITA has the people and the robots to be able to do, and we have 2 robots as well, but we don't have the number of surgeons who may be able to do both. So that's one of the issues. I think that, as you said, incorporating veno-venous bypass and portocable shunt and performing the clamping of the cable above the portocable shunt, we would be able to increase the number of patients who may be eligible for robotic liver transplant. I know in India, ever since I moved to India, I've not done veno-venous bypass on any patient. And I can fully understand what Professor Sixu is saying, that they have no experience in veno-venous bypass. But again, I've worked in a system for 20 years. And in the beginning, I went into liver transplantation in '91. For the first 5 years, we have done all cases with veno-venous bypass. So we are comfortable, and I think veno-venous bypass could potentially be an advantage. It may just be a mental block for us in the East to actually bring in and do it, and the additional cost of veno-venous bypass. But I think if the number of cases is going to improve, if the safest way to do it is through clamping the cable and doing the implantation, veno-venous bypass would help tremendously. But then I've seen videos of from DITA where he puts a side clamp and does it as well. But then portal clamp will be a long duration as well. So even a portal clamp for 1.5 to 2 hours, because sometimes we have to clamp the portal vein even before completely dissecting the cable and a cable from the liver and the cirrhotic liver. So the portal clamping is actually longer than if you were to do an open operation, where you only do the portal clamp just before taking the liver out.
I believe that if you're able to implant a graft, it's a piece of cake to do a temporary portocable shunt, but that's just
absolutely. I agree with that. So I'm actually seriously considering it. There is absolutely no wrong in actually going through the phase. That's why I'm saying the upper midline incision that we do now is not an operation for the future. I'm not saying that we won't go into. At the end of the day, even fan and still is not completely minimally invasive anyway. So the upper midline phase we are going through for implantation is, again, a phase in the development of this technique for us, rather than me saying I'm only going to start with a fan and steel and going to implant, and then having to do a midline incision in those patients to sort them out for hemostasis. That would be unacceptable in my mind.
All right, Daniel, you want to conclude?
No, you please.
So anyway, thanks for all of you to being here. Thanks for the American Journal of Transplants for organizing this series. Obviously, this is, extremely innovative. This is, in the verge of, complete fascination, and we'll see what's going to happen in the next year. So I appreciate everyone's time. I want to thank also Daniel, my co-chair. I think this was 2 very interesting webinars. I remind everyone that these are online, and there's, the papers are, discussions from the first authors online. And I hope everyone has a, good day, good night, or good morning.
Okay, thank you. Thank you, everyone.
Thank
and
you.
we are fortunate to have the best experts in the world. So thank you very much.
Pleasure to see you all.
Thank you.
Very
For
much.